Hey, nurses and nursing students. Want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology crossword puzzle book from MedEd 101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse. In this section, I'm going to cover pharmacodynamics, some important terminology, and some kind of common sense things that you need to know. So first off, some basic terminology that's really, really important to know. This impacts kind of how drugs work in the body. And I would say the two most important terms are agonist and antagonist. So an agonist is something that stimulates a receptor or causes a physiological response. Okay, and I've got examples coming up here as well. So again, agonist stimulates. That's a good way to remember that. An antagonist is often called a blocker, or it blocks a physiological function. Okay, so those two are really, really important. We also have things that are called partial agonists. There aren't a lot of drugs that work this way, but a good example of that is a partial agonist at the opioid receptor. Buprenorphine is a good example of that, where it kind of stimulates the opioid receptor, but doesn't allow other medications to stimulate it too far and get patients into opioid overdose. So that's kind of the utilization on a partial agonist. So let's talk a little bit more specifically here. Great example of an agonist, so a medication that stimulates or activates a receptor. Beta agonist, albuterol. So this is kind of that classic medication that can be inhaled by nebulizer or by an inhaler. And this medication, albuterol, stimulates, again, agonist, stimulates beta adrenergic receptors. And with receptors, when we're talking pharmacodynamics, we can have numerous subtypes of receptors. So basically, these receptors look pretty similar, but there's some small subtleties that make them a little bit different. So with that said, drugs, molecules, hormones, they can bind with different stimulatory effects on different variations of receptors. So albuterol, it's considered by broad category as a beta agonist, but more specifically, it is a beta 2 agonist. So it primarily prefers the beta 2 receptors. Those beta 2 receptors are more commonly found in lung tissue. And so it opens up the airway and allows a patient to breathe a little bit better. Now, if we take too much albuterol, we can lose some of that selectivity, and we can have more effects on beta 1 receptors as well as beta 2 receptors. So, the higher the dose, the more frequently we use albuterol, we can stimulate beta 1 action. Okay? And those receptors are on the heart more so. So when we stimulate the beta 1 receptor, we get an increase in heart rate. And so when you see adverse effects from albuterol, you may hear patients report that they're feeling like their heart is racing. That's a potential adverse effect. And the more albuterol the patient takes, the more and more likely this is to happen, because we kind of lose that selectivity for the beta 2 receptors on the lungs. And now we're starting to hit those beta 1 receptors and have that agonist or stimulatory action on the heart as well. Now, beta blockers, the exact opposite, right? So classic example here, we've got metoprolol. these block or stop the action that corresponds to when something binds to the beta receptor. So by blocking those beta receptors, with metoprolol here specifically, metoprolol blocks primarily beta 1 receptors. So how is that helpful? Well, in patients that have tachycardia, racing heart rate, atrial fibrillation, we may use a medication like metoprolol to reduce that heart rate and potentially manage atrial fibrillation. Now here again, same thing. We can have negative adverse effects. So if we use metoprolol at a higher dose, and now we're starting to maybe lose that selectivity, and now we're starting to block beta 2 receptors, there is the potential that could worsen breathing. Okay? So again, and in the body, we obviously have endogenous molecules like epinephrine and norepinephrine that are released at various times. Generally, it's through fight or flight type reactions that epinephrine and norepinephrine are released, and I'll talk about that going forward here. But we have kind of endogenous hormones that have this interplay with those receptors, and are stimulating and released more in certain situations. But we use medications to kind of cheat that system a little bit. And that pharmacodynamic impact based upon which receptors are blocked and which receptors are activated, we can have, the potential for therapeutic benefit in asthma and COPD as far as beta 2 agonists go. And we can have potential benefit therapeutically with beta 1 blockers like metoprolol. But we can also have the adverse effects as well. So hopefully that kind of gives you a sense. It's a great example of how agonists and antagonists work at various receptors. Now that partial agonist, so I alluded to an example before. Another good example, I alluded to the buprenorphine example before. Another good example is varenicline. So varenicline's mechanism of action is it's a partial agonist at alpha-4 beta-2 nicotinic receptors. So think nicotine. So in patients with looking to undergo smoking cessation, this medication can kind of help stimulate those nicotinic receptors partially, but then it also helps block a full agonist like nicotine to kind of reduce that reward and give that high. So even if a patient does smoke while they're on this medication, they might not get as much of the reward type of sensation. So that's kind of the role for most partial agonists in this setting. All right, some other terminology with pharmacodynamics. So potency, this is the amount needed for the effect to happen. So if something is very, very potent, we need just a small dose, okay? So fentanyl is a good example. It's a very, very potent opioid, much more potent than morphine. So we need a lot more morphine to get the same effect that a small amount of fentanyl would cause. Efficacy, so this is the effect or maximum effect a drug can produce. This is something that we're looking for. We definitely want drugs to be efficacious and produce the effect, whether it's treating an infection or something along those lines. Therapeutic index, so this is basically the target range that we can hit where we're getting the effects we want and we're not getting too much and having adverse effects. So in essence, we want a large therapeutic index. Ideal drug would have a large therapeutic index where we've got a big window of efficacy of where that medication works, and it takes a lot of drug to cause side effects, okay? We've got a lot of examples of narrow therapeutic index medication, and many times these are meds that require lab work, okay? So we're monitoring and tracking drug levels because it's really, really sensitive or it's a really, really tight window between not getting enough and the medication not working and getting too much and causing adverse effects. So classic examples there: warfarin, Synthroid or levothyroxine, lithium, phenytoin. So many of the seizure medications sometimes have a tight window of, weighing that line of, okay, we've got too much, now we're causing toxicity. Okay, we got too little, now, the patient had a seizure. So those are the type of medications, those narrow therapeutic index, that often require lab work to monitor their drug levels. Receptor affinity, I alluded to that a little bit with the beta receptors and the selectivity. So if a drug has higher affinity, it binds that receptor more tightly and doesn't allow other drugs to bind it and displace it. So naloxone's a good example there. So this is the opioid reversal agent. So it basically binds those opioid receptors tightly. So other opioids in the bloodstream, fentanyl or whatever opioid the patient potentially overdosed on, naloxone doesn't allow those other drugs to bind there very easily, and that it can help us treat opioid overdose. Lower affinity, so if it doesn't bind a receptor very tightly, that's going to impact potency. So obviously, if it doesn't bind the receptor at all, we're going to get no effect on that receptor. If it binds it a little bit, it's a lower potency drug. We're going to need more and more of that drug to cause an effect. And then I alluded to the receptor subtypes already. We've got histamine receptors, we got alpha receptors, we got tons of different receptors in the body, and different molecules, different drugs can bind these receptors at different affinities and tightness. So that's an important thing that we'll cover as we talk about specific medications. But different drugs tend to bind different subtypes more tightly or less tightly. And that binding and the actions from those receptors vary, as I alluded to with the beta receptor example. Beta 2, there's significantly found on the lungs, and beta 1 are more found on the heart. I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review Course at meded101.com/nurse. MedEd 101's Nursing Pharmacology Review Course is built to make meds finally click. You'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed by pharmacology experts for nurses. Stop memorizing, start understanding pharmacology at meded101.com/nurse.